This conference will now be recorded.
Primary College General Hospital is the host. We have interesting cases, and they will be followed by an international lecture by an international speaker, followed by another lecture by our Professor Hamatsa. He's going to be our guest lecturer today. So today I will invite Dr. Kashif Jahangir so that he can moderate the session. Dr. Kashif.
Bismillahirrahmanirrahim. Thank you all for attending the plenary meeting held at Ilama Equipment College. So we've lined up 4 cases from the Department of Ophthalmology, and there's going to be one international case from Dr. Azam Qureshi, and one case is going to be from Professor Hamad Ayub, who is now currently working as Professor of Ophthalmology at King Edward Medical University. So by starting the meeting, I invite Dr. Hassan to start with the Tilawat of Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. يا أيها النبي إنا أرسلناك شاهدا إنا أرسلناك شاهدا ومبشرا ونذيرا يا أيها النبي إنا أرسلناك شاهدا ومبشرا ونذيرا وداعيا إلى الله بإذنه وسراجا منيرا وبشر المؤمنين بأن لهم من الله فضلا كبيرا ولا تطع الكافرين والمنافقين ودع أذاهم وتوكل على الله وكفى بالله وكيلا. صدق الله العلي العظيم وصدق رسوله النبي الكريم. तर्जुमा कंजुल ईमान इमाम अहमद रज़ा खान रहमतुल्लाह अलैह। अल्लाह के नाम से शुरू जो निहायत मेहरबान हमेशा रहम फरमाने वाला है। ए गैब की खबरें बताने वाले नबी, बेशक हमने आपको बनाकर भेजा हाजिर और नासिर और खुशखबरी सुनाने वाला और डर सुनाने वाला और अल्लाह ताला को अपनी तरफ बुलाने वाला अल्लाह ताला के इज़्न से और चमका देने वाला रोशन आफ्ताब, और मोमिनों को खुशखबरी सुना दीजिए कि आपकी सूरत में उन पर अल्लाह का बहुत बड़ा फजल हुआ, और काफिरों और मुनाफिकों की खुशी ना करो और उनकी एज़ा पर दरगुजर फरमाओ और अल्लाह पर तवक्कल रखो, बेशक अल्लाह ही सबसे बेहतर साज़गार है। वअलैना इन्नल बलाग।
Subhanallah. Now I would like to formally start the meeting. So we've lined up 4 cases from our local presenters who are basically residents in the Department of Ophthalmology. We've tried to include cases from all sectors, including the medical retina, surgical retina, oculoplastics, and glaucoma. So by starting with the first case, I invite Dr. Inamur Rahman, who is currently working as a resident in the Department of Ophthalmology and Lama Department.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Inamur Rahman, working at Jinnah Hospital, Lahore. Today we're going to talk about this patient, 36-year-old male resident of Lahore, presented to us where he works as a security guard. He presented to us with bilateral sudden decreased vision in both eyes. Bilateral sudden decreased vision in both eyes since one day. He experienced headache, dizziness, and nasal bleed on 13th of June. Next morning, he experienced bilateral sudden decreased vision. It was greater in right eye. It was associated with flashes of light and inability to perceive colors. There was no previous history of ocular trauma or surgery. He's a slight bio, but he's not using his glasses. Initial ocular examination showed visual acuity of 660 in right eye and 624 in the left eye. Color vision was defective in both eyes. Pupils were reactive. No RAPD was present. Extraocular motility was full. Anterior segment examination revealed clear cornea, phakic, and IOP was 12 in both eyes. AC was quiet bilaterally. Posterior segment examination revealed multiple yellow-white subretinal lesions in posterior pole in both eyes. There were more so in the right eye as compared to the left. There was macular edema in the right eye, and there was bitter cells of +1 in both eyes. These are the fundus photographs of the patient. We can see multiple yellow-white subretinal lesions in both eyes. This is the OCT of the patient on the day he presented to us. We can see this perifoveal edema, PEDs, and ISO junction is disrupted in right eye. This is the close-up of the OCT. IDDs were white dot syndrome, VKH, sarcoidosis, tuberculosis, and syphilis. Our provisional diagnosis was VKH. We planned FFA, but patient went MIA for about 3 weeks. He came back to us on 7th of July for follow-up. At that time, his vision was 624 in right eye and 618 in the left eye. We had put him on systemic steroids at the time. This is the OCT when he came for first follow-up. We can see multiple serious detachments in the right eye. These were the investigations we had done. CBC, quantiferin gold, serum AS lipid profile, HIV markers, chest X-ray, and VDRL. This is the FFA of the patient, which we did on the 7th of July. This is the red field pictures. You can see yellow-white lesions in both eyes in the posterior pole. This is the arterial phase. We can see fluorescent spots, a couple of fluorescent spots in this arterial phase. This is the AV phase. We can see multiple hyperfluorescent dots corresponding to white spots. In the posterior pole, there are more in right eye. We can see in the late staining, there is no increase in fluorescence or increase in size of the spots. There is also subretinal pooling in the right eye. This is the left eye, where we can see the multiple hyperfluorescent dots in late stage. This is the FFA of the right eye. Showing all four pictures. This is of the left eye. We had put him on systemic steroids. We also administered subtenon, triamcinolone, and topical NSAIDs. Now we're going to go through the leakage features and White syndrome features and see what features are present in the patient. In prodromal stage, there is headache, dizziness, nausea, orbital pain, photophobia, and fever. In our patient, he experienced headache and dizziness. In uveitic stage, we can see there is hyperemia and edema of this, multiple serous detachments, vitritis and granulomatous anterior uveitis. In our patient, we saw multiple serous detachments on OCT, and vitritis was present. In convalescent stage, there is alopecia, poliosis, vitiligo, and depigmented fundus. No such feature was seen in the patient. Auditory signs were also not present in the patient: sensorineural hearing loss, tinnitus, or vertigo. Neurological signs include fever, headache, stiffness, neck stiffness, and vomiting. Headache was seen and neck stiffness was also present. No dermal signs was present. And White syndrome, now we're going to go to White syndrome features in youths. It's a female predominant disease, usually presents unilaterally. There is a foveal granularity, which is the characteristic feature of youths. There is also disc edema, vitritis, RAPD, blind spot enlargement, photopsia, and scotomas. In our patient, there was vitritis and photopsia. In APMPB, there's equal presentation in males and females. It usually presents bilaterally. We can see placoid lesions in posterior pole, subretinal macular fluid. It is also associated with the erythema nodosum, and HLA-B7 and ER2 are mainly positive in 90% of the cases. Serpiginous choroiditis, it's a male bilateral disease. Snake-like lesions emanate from optic nerve. There is anterior uveitis and vitritis. And punctate inner choroiditis, it's mainly female predominant disease, bilateral presentation, and it's mainly involving the macula. Multifocal choroiditis, it's bilateral disease, female predominance, anterior uveitis, and overt lesions in posterior pole and mid-periphery. Vitritis is also seen. Bloodshot retinochoroiditis is a female predominant bilateral. It's a gradual progression of disease vision, and each LA829 is 90% positive in these patients. Now we're going to go through FFA findings in BKH for dot and in our patient. In BKH, there are multiple hyperfluorescent dots at the level of RPE, followed by subretinal pooling within the detached areas. In APMBP, there is early hyperfluorescence and late hyperfluorescence. In youths, there is early hyperfluorescence of dots with late staining. Serpiginous choroiditis, there is early hyperfluorescence and late hyperfluorescence. Punctate choroiditis, early hyperfluorescence and late staining of lesion. Multifocal, there is early hyperfluorescence and late hyperfluorescence. Bloodshot retinochoroiditis, there is extensive vascular leakage with disc and vessel staining. In our patient, as we saw in the FFA pictures, there were early punctate hyperfluorescence with late staining corresponding to the white dots. subretinal pooling was appreciated in late phases of angiography in the right eye. This is his latest fundus photograph picture. We can see the cell white dot lesions. This is he's using systemic steroids at almost 100 mg per day. So, anybody want to give his expert opinion?
I just would like to add a few words. एक मतलब दो मेडिकल और सर्जिकल दोनों के एक्सपर्ट्स माशाल्लाह रेटिना के हमारे पास बैठे हैं तो इनसे फायदा लेना चाहिए. I just wanted to ask मतलब हम इस वक्त इसको ना व्हाइट डॉट और वीकेज दोनों में फंसे हुए हैं जो सच्ची बात है कि इसको व्हाइट डॉट में रखें या वीकेज में रखें क्योंकि उसकी प्रेजेंटेशन है बायलैटरलिटी एक तो थी सेंट्रल ऑब्जर्वेशन अब वीकेज के लेकिन बाकी फीचर सारे वीकेज का ऑलमोस्ट आ रहे हैं क्योंकि इसमें क्लिनिकल आई ऑकुलर फीचर्स है एफएफए के ऊपर इसके कूलिंग भी आ रही है सबरेटिनल फ्लूइड ओसीटी पे भी आ रहा है. ठीक है जी. अब वो ये इन चीजों को दिमाग में रखते हुए अगर अब ये देखते जाए ये एफएफए में मैं आपको दिखाता हूँ कि अगर ओसीटी हम देखें इसका लास्ट एक्सुडेटिव आरडी क्लिनिकली नहीं है लेकिन अगर आप वो लास्ट स्लाइड पे जो इसको जो 4th नंबर स्लाइड है उसमें देखें तो ये थोड़ा सा हमें ज्यादा कूलिंग का पॉइंटर है पॉइंटर ये मोस्ट प्रोबेबली व्हाइट डॉट इट्स नॉट ये एरिया में ये कूलिंग का सिस्टम है ओसीटी में आपको दिखाते हैं ये अगले ये जो है ना वो विकेश में इसको लेके जा रहा है डेफिनेटली ये राइट में ही है और राइट ही में इसका बेसिकली वो जो कूलिंग आ रही है ना जो सबरेटिनल फ्लूइड के एफएफए के लेट फेज में वो भी लॉजिकली आप स्टीरॉइड दे रहे हो हां वो अभी होगा तो कोई स्टीरॉइड दे रहे हैं इट्स नॉट ठीक है व्हाइट डॉट में स्टीरॉइड्स का अगेन रोल है नहीं है लेकिन अगर आप शुरू कर देंगे तो लेट्स सी के 4 वीक्स पे फॉलो अप में डेफिनेटली विजन में इंप्रूवमेंट आई है ये तो ठीक हो रही है हां स्टीरॉइड कैसे दवाई दवा बनती दवा तो should we continue with the steroids अगर आप स्टीरॉइड दिए 4 वीक्स में अगर फ्लूइड नहीं रहता तो उसके बाद एटलीस्ट 3 मंथ्स इसको कंटिन्यू करने चाहिए स्टीरॉइड फुल डोज में रिकरेंस हो गई अदरवाइज इसको 3 मंथ्स मिनिमम रखते हैं so we'll continue with the steroids for the about 1.5 months more क्योंकि डेढ़ महीना हो गया almost 12-14 पेयर 4 वीक्स पे अगर he's a little bit overweight so इसको अभी हम तकरीबन 20 में भी है वो मसला ये है कि जब ये फ्लूइड एब्जॉर्ब हो जाए उसके 3 नहीं उसके बाद 3 महीने आपने फ्लूइड एब्जॉर्ब होने के 3 बाद ठीक सर ये सारा किया हमने बिल्कुल हमने सार्कोइडोसिस ट्यूबरकुलोसिस इन्वेस्टिगेट सारा किया तो वो कुछ नहीं. थैंक यू वेरी मच डॉक्टर Rinal for a very interesting case. So next I would like to invite
I have a small announcement that those who are presenting the residents, these resident presentations will be marked by the judges, and we will choose the first, second, and third position holder. And not only this, that they are choose today first, second, and third holder position holder for the grand clinical meeting that we are holding at OSP Lahore annual conference. Those who are winning in this competition, those who stood first in the competition, from all the Lahore Institute, they will compete in grand clinical meeting at the Lahore of Kalmo. And the winner of that clinical meeting will be the grand winner of all the clinical meeting. So be cautious, take much interest that you should have very good or interesting presentation so you can win over here and then you can finally reach the grand competition round. Thank you.
Good documentation as been done in this case is the first step in progressing the scientific literature. आपके पास तस्वीरें होंगी तो आप केस रिपोर्ट पब्लिश करेंगे तो दिस इज अ गुड बिगिनिंग आई मस्ट आपने हर स्टेज की पोस्ट एफेक्टिव या ओसीटी या फंडल फोटोग्राफ ये सारी बातें रखी ताकि केस को कल पब्लिश करनी हो तो ये काम है But one thing एक तो मिसिंग मुझे लगी है वो ये है कि जब आप डिफरेंशियल डायग्नोसिस डिस्कस कर रहे हैं उसमें आपने कोई फोटोग्राफी ये वाइट डॉट सिंड्रोम है ये न्यूज है ये आपके पास बंडल कैमरा है यहाँ पे आपके पास तो एक टूल होना चाहिए बंडल फोटोग्राफ का ओसीडी का है आपके पास ताकि इस तरह की प्रेजेंटेशन में आप जो भी हो वो फिट कर सकें ताकि ऑप्थेल्मोलॉजी इज वेरी कलरफुल मतलब इसमें बड़े फोटोग्राफ और बड़ी इंटरेक्शन होती है बजाय ये कि आप सारा टेक्स्ट ही पढ़ते जा रहे हैं उसके लिए आप
Thank you very much. So we'll continue with the presentations. So now we'll continue with the clinical cases. The next case is going to be presented by Dr. Sana Chaudhary.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Sana Chaudhary, third year resident of ophthalmology here, and I'm working under supervision of Dr. Qasim Lateef Chaudhary. Today I'm here to discuss a case of refractory juvenile glaucoma and how did we manage it. I have no financial disclosure. A patient XYZ, 14 years old, female, resident of Jhan, presented to us with complaint of decrease of vision in both eyes for 7 years, which improved slightly with glasses. On taking further history, we found out that patient is diagnosed case of glaucoma and got surgeries done in both eyes for glaucoma management. Patient is high myope and using glasses for 7 years. Talking about her past ocular surgical history, she got her trabeculectomy with mitomycin C done at Jinnah Hospital 3 years back in the right eye, while in the left eye she got 2 trabeculectomies with mitomycin C done elsewhere. There is no history of trauma, diabetes, hypertension, or any systemic surgery. A patient was on full medical therapy for glaucoma management, including oral acetazolamide and all 4 eye drops for glaucoma. Family history was not significant. Father is a farmer by profession, and patient belongs to a middle socioeconomic class. Coming towards ocular examination, visual acuity was 6/24 in the right eye and 6/12 in the left eye, and there was no improvement with refraction. Bilateral pupils are round, regular, and reactive. Color vision was normal in both eyes, and extraocular movements were full and intact. Okay, extraocular movements were full in both eyes. IOP was measured to be 14 millimeter of mercury in the right eye, and the left eye it was measured 28 millimeter of mercury. On Cyclic examination of anterior segment, we found that trabeculectomy scar with well-formed conjunctival bleb and PI at 12 o'clock position in the right eye. While in the left eye, there was conjunctival scarring and well-formed scarred blebs at 12 o'clock and 2 o'clock position and PI at the same positions. On gonioscopy, trabecular brushwork was visible in both eyes. On posterior segment examination, bilateral laminar dot sign present. Bilateral discs are pale with deep cup, and cup disc ratio is 0.9 in the right eye and 0.8 in the left eye. Bilateral macula are healthy. This is optical coherence tomography scan of the right eye showing increased cup disc ratio. OCT scan of the left eye with the same findings. Central corneal thickness was measured to be 536 micrometer in the right eye and 552 micrometer in the left eye. Advanced glaucomatous damage can be seen in both eyes on visual fields. So the patient was on full medical therapy for glaucoma and there's history of 2 failed traps. We considered it a refractory juvenile glaucoma and we proceeded with Ahmed glaucoma valve implantation in this patient. Okay, this is actual surgical video. Peritomy is being done, hemostasis secured, valve is being primed with 27 gauge needle and you can see there is fluid wave which means the valve has been primed. The length of the plate is 5 millimeter and now 8 millimeter behind the limbus. The valve will be sutured to the globe by Prolene 60 cutting needle which is non-absorbable. Valve is going to be implanted in the intranasal quadrant. The tube is cut to the acquired length and the bevel of the tube should be upwards. Okay, the piercer knife is used to make a partial thickness scleral tunnel. This is a very technical step and the length of the tube is 4 millimeter and through this tunnel tube will pass through. Okay, now we are passing the tube to the tunnel. 1.5 millimeter behind the limbus with 23 gauge needle entry port into the AC is made for tube entry into the AC. Meanwhile, viscoelastic gel is put into the AC to avoid sudden hypotony or suprachoroidal hemorrhage. And then the tube is put into the AC and conjunctiva will be closed with ethylone 10-0. This is the post-op picture of this patient with tube into the intranasal quadrant. Now I would like to present the intraocular pressure which we measured at various post-op visits. The intraocular pressure reduced from 28 millimeter of mercury to 8 millimeter of mercury on first post-op day. After 1 week it was 10 and after 2 months pressure maintained around 12 millimeter of mercury. AG valve implant is a silicone tube connected to the silicone sheet valve by polypropylene body. It works on the mechanism that aqueous is passed in the tube between 2 silicone elastomer foils. The initial pressure which is required to break the adherence of the membrane often exceeds over 100 millimeter of mercury which is provided by priming. Afterward, the valve will close when the pressure falls below 8 and it will open when the pressure exceeds above 12. It means that it allows one-way flow of the aqueous. Granulomatous reaction occurs and filtration of blood forms. Okay, this is the picture of AG valve implant showing its various parts, plate and disc, and the tube is inserted into the ridge. Previously, we used the valve in patients with the history of failed tuberculotomies, but they can also be used in patients with neovascularization, with active inflammation or severe conjunctival scarring. But now the studies showed that we can use this in patients after failed medical therapy as first-line surgical treatment. In patients with thin sclera, severe limbus scleral thinning, extensive fibrosis of conjunctiva and ciliary block glaucoma, AG valve implantation is contraindication. Okay, what are the possible complications which can arise after AG valve implantation? They can be tube cornea touch, which can be avoided by putting the tube into the AC, into the plane of the iris. The flat chamber and hypotony, which can occur when the tube is not snugly fit and there is leakage of the aqueous from the tube. Tube can get occluded, plate migration, valve malfunction, exposure of the tube or plate. And diplopia can occur when there is large bleb or there is involvement of extraocular muscles. Okay, these are the pictures of complications tube cornea touch. The second picture plate is exposed. Tube is blocked by iris and there is plate malposition with diplopia. Now, comparison of AGV with other filtration surgeries. Here I have shared some studies which are conducted internationally and they have compared AGV with other filtration studies. They concluded that AGV has better efficacy and risk profile. This is a meta-analysis and it was conducted by Dine Havo et al. And they concluded that AGV was equivalent to trap in reducing IOP. However, patients with AGV had a reduced risk of adverse effects. Okay, this is the study conducted by Rai et al. And they concluded that AGV was effective in reducing IOP in patients with failed trabeculectomies. This study was conducted on pediatric patients and they concluded that AGV was effective in reducing IOP in patients with pediatric glaucoma. So according to studies, at first year follow-up, the two patients were more likely to maintain intraocular pressure and avoid hypotony as compared to patients with TRAP. However, AGV patients needed more supplemental therapy. At 5 years follow-up, we observed that the IOP pressure control was similar in both groups. However, patients with TRAP needed more supplemental therapy. These are the references which I used in this presentation. I would like to acknowledge and thank my faculty members, respected Dr. Raza Ali Shah, Madam Uzma Hamza, Dr. Muhammad Hassan Ali, and Dr. Waqas Asghar for helping me out in this case presentation. All right, thank you so much, everyone.
What are other drainage devices? Any name?
So, Molteno device in express shunts.
नए वाले नए कौन से हैं? What are the new devices in filtration? क्या क्या? Eye stands होते हैं, L stands होते हैं. वो trabecular measurement में small pipe की तरह रखे जाते हैं. ठीक है, ये साइज में बड़े होते हैं, इनकी कॉम्प्लिकेशन थोड़ी ज्यादा, तो आप अर्ली स्टेज में आई स्टैंड्स या एल स्टैंड्स वो जिस तरह आप इंजेक्ट करते हो आईएल, इस तरह का इंजेक्टर होता है जिसके आगे होता है ट्रेबेकुलम में आप मोनिस्कोप के जरिए इंजेक्ट कर देते हैं. और कोई सवाल पूछना चाहें? Just want to add that here we have started and we have started to implant this AGV valve, and there are two plates F6, F8. They are available. The F8 is a smaller one, and it has got a better post-op success rate. The reason for that is that it causes less diplopia due to its small size, and we have to prime it first. And priming is important. And the other thing which she has mentioned is that the bevel should be up. And what we have done here, we have a case of series of 8 to 9 cases which we have implanted, and here we have seen that if you do a scleral tunnel, which we are making a scleral tunnel, and this scleral tunnel in cases of thin sclera, it is difficult to do it. There you have to put a corneal or a scleral graft over it to cover the tube. But with this, we haven't seen any tube erosion or any infection in it. But with a corneal tectonic graft or a scleral graft, we do see some of the infections later on. But we have a study of around about 1 year, and the results are very promising. And inshallah, we are hoping to present paper, and we are comparing, because one of the this case specifically had two failed traps, one on the supronasal and one on the suprotemporal. So there was a large conjunctival scarring present. So what we did, that we went intranasally, made a pocket, and we went inside, and it should be placed 8 millimeters behind the limbus, where you get appropriate space for that. And there are two different ways of stitching it. Either you can stitch the plate separately, or you can put a proline 50 or 60 stitch, and you can pass through it and you can tie it together. That is appropriate, and I think what we have done and we are doing, we haven't seen any complication regarding the dislodging of this or retraction of this valve. And hopefully we will be doing it.
Actually, event implant is more common in UK and Western countries than Ahmed. यहाँ पे हम Ahmed ज़्यादा करते हैं, वहाँ event ज़्यादा करते हैं. So one important consideration is early hypotony. एंड वो जो मैंने ऑब्जर्व किया वहाँ पे वो ये था कि वो ट्यूब में एक 40 सिल्क डाल देते थे ट्यूब ट्यूब कर सो दैट द हाइपोटनी डज नॉट अकर जिस वक्त आपने और ज्यादा आईओपी यूज करना है वो ब्लैक से निकाल ट्यूब में से तो क्लोज सो इस कॉन्टेक्स्ट में टीवीटी व्हाट इज टीवीटी एनी आइडिया ट्यूब वर्सेस ट्रेविकुलर ये सबसे बड़ा मेटा एनालिसिस चल रहा है 5 साल की स्टडी है अभी तक ये कंफ्यूजन दूर नहीं हुई कि ट्रेविकुलैरिटी विद माइक्रोमाइसिस सी बेहतर है या ट्यूब शंट्स बेहतर हर एक अपने क्लास ऑफ मॉडल्स है तो अमेरिकन जर्नल ऑफ ऑप्थेल्मोलॉजी में आप पढ़े तो टीबीटी स्टडी जो है ना उस पे
One thing just want to add about it that with this we have got a one valve flow and prime जब आप कर देते हैं then इसका जो pressure है that is it stays between 8 to 12 mostly and therefore the doctor साहब ने जो valve की बात की it's not available when it will be available we will be doing it but still it is a costly one and to get it and to get the patients in this sort of a government setup is difficult. So we just educate to the patient on अगर जो कोई ले आता है तो then that's good. And this is very important that we should proceed to a better whatever जो है results and better devices what we are having. And in that one thing more that the hypotenuse की बात आप कर रहे हैं उसमें ये है कि if we pass 23 इसकी जो है it's like a 23G की जो ट्यूब की फिटिंग है तो once you enter with this 23G you don't make the tunnels sideways go sideways just enter and put it out उससे ये snugly fit होता है और hypotony नहीं होगी otherwise वो hypotenuse हो जाता है
Thank you very much for a very healthy and productive discussion. I formally would like to welcome Dr. Azam Qureshi, who is basically our international speaker for today, and I've heard that he's online. And welcome you, Dr. Azam Qureshi. So next the talk will be from our resident, Dr. Mohammed Ahmed. Dr. Ahmed.
Bismillahirrahmanirrahim. I am Dr. Mohammed Ahmed, PGR in Eye Unit 1 of Jinnah Hospital, Lahore. Today I am presenting the case a 13-year-old female presented with drooping of right upper eyelid with a downward and outward deviation of the right eye since birth. This is the picture of her initial presentation in which we can see that her right upper eyelid is dropped and outward and downward deviation of her right eye. As she had no history of birth trauma or trauma to the eye or any medication usage, but in the past ocular history, she had previous history of frontalis sling and right lateral rectus recession and medial rectus recession 9 years back. At that time, cosmesis was achieved, but after 2 years, it was reverted back to its original position, and she had no any other ocular surgery history. After going into past medical history, she had no known medical illness, and in her family there is no any other ocular disorder present in her family. In clinical examination, her best corrected visual acuity in the right eye was 624 and in left eye was 6/6. And in near visual acuity, it was n/12 in right eye and n/6 in left eye. Both eye pupil was round, regular, and reactive, and RAPD was negative in both eyes. This is the extraocular movement of this patient. As we can see that the extraocular movement in the right eye are not regular and synchronous with the left eye. This can be due to the previous surgeries which was attempted on the horizontal muscles or apparent regeneration of the children. Now going towards the clinical examination of the screen, on her blood test, there was right isotropia of 35 degrees and right hypotropia of 20 degrees. In cover and cover test, right exotropia and hypotropia was noted, and prism cover test show 70 prism diopter of exotropia. This is the picture of this patient in which uh, uh, we have moved the upper eyelid upward, and we can see the right reflex in the right eye, showing that the ectotropia of 30 to 20 degrees, 35 degrees, and hypotropia of 20 degrees. Now coming toward the examination of the ptosis, the lid crease was absent and there was poor levator function and severe ptosis. The marginal reflex distance was -1 and the Bell's phenomena was positive with negative markers conjoined. These are the picture of the patient which showing the severe ptosis and poor levator function, and last picture shows the Bell's phenomena is positive. In slit lamp examination, the lid and lashes of both eyes are normal, conjunctiva of both eyes are normal, both eyes cornea are clear, anterior chamber was quiet, and bilateral fundus was normal. So we made the diagnosis after these examination was the congenital cerebral palsy in this patient. Now we have to manage the condition as this patient had previous surgery of ptosis and horizontal muscles, so it was a very difficult decision to make. So we planned two surgeries in this patient. In first surgery, we addressed the vertical deviation in which inferior rectus was released and superior rectus was resected to the level till the hypotropia was corrected and inferior rectus was attached at that place. And we also did superior conjunctival recession and inferior conjunctival recession. And along with we did frontalis sling with 40 proline to elevate the eyelid. This is the picture of the patient first post-op in which we can see the patient hypotropia was corrected and lid is elevated, but there is still exotropia in this patient. This is the picture of this patient after 2 months after the first surgery, in which we can see the eye is still in exo. So now we have to plan for the second surgery. As in this eye, horizontal muscles was already operated, so we plan to do the horizontal muscles of the left eye, in which we did resection of the medial rectus 6 millimeter and resection of the lateral rectus 8 millimeter. And this is the picture of us post-op day after the second surgery, in which we can see the ectotropia of the right eye is corrected. And this is the picture of the patient after 1 month after the second surgery, in which we can see the results are normal and right upper eyelid is in its position and normal position of the right eye. Now coming toward the some explanation on third nerve palsy in children. If there is third nerve palsy in children, we have to exclude any space occupying lesion present or not. And the other common causes include it can be congenital, local inflammation can also be the cause. It can be also to the trauma, aneurysm, myasthenia gravis, or migraine. If there is strabismus in the children, we have to go for the refractive error and after administering the cyclic. And the congenital causes in the patients can be due to a developmental cause or due to burst trauma. In developmental, there may be aplasia or hypoplasia of the oculomotor nerve nucleus, and during birth there may be trauma to the eye by the molding forces acting on this skull during the labor. And there can also be intrauterine trauma, and really it can be due to the infections such as meningitis. Here is the table which shows the complete summary of the third nerve palsy. If there is complete third nerve palsy which involves the superior and inferior division of the nerve, the muscles involved are medial rectus, superior rectus, inferior oblique, and the levator. And the eye has only or ocular motility of exotropia, hypotropia, and intorsion. The restricted movements are adduction, elevation, and depression. If superior division is involved in the palsy, then the muscles involved are superior rectus and the levator, and only hypotropia is present. And the restricted movement is the elevation, but in both the conditions process is present. And in going to the divisional palsy of the third nerve, it can be due to aneurysm or the orbital disease. If the superior branch is if the superior branch is involved, it is in adults, and it presents as the acquired monocular elevation deficit ptosis. And inferior branch is usually associated with orbital pathology. And there may be also be the aberrant regeneration of the third nerve. And aberrant regeneration of the third nerve or only occurs in congenital or traumatic third nerve palsy. Ischemic third nerve palsy do not cause the aberrant regeneration of the third nerve. Now going towards the oculomotor synkinesis, in which there is the formation of the secondary connection of third nerve with the ipsilateral trigeminal nerve, and when a patient eats something, there is either synergistic movement of the lid or extraocular muscles, and cyclic oculomotor spasm. It is very rare condition, and very small number of children have reported this in congenital third nerve palsy. In these patients, patient present with the cranial 3 palsy but with regular short bursts of spastic movement causing elevation of the lid, adduction of the eye, miosis, and increased accommodation. This is all for today. Thank you.
So, see, you have presented the case well, but you have not mentioned what is the condition of the pupil. When it comes to the third nerve palsy, the most important thing is whether the pupil is involved or spared. If a pupil involving third nerve palsy is recent in onset, is required, then you have to do radiological investigation.
सर मेंशन किया है pupil round reactive है
ठीक है, dilated
नहीं
गुड ओके सो थर्ड nerve palsy में अगर वो एक्वायर्ड हो और डायबिटीज और हाइपरटेंशन की इसकी ओर हम ज्यादा इन्वेस्टिगेशन में नहीं जाते, लेकिन अगर डायबिटीज हाइपरटेंशन नहीं है और यंग पॉपुलेशन है तो उसमें जरूर इन्वेस्टिगेशन करानी चाहिए कि एंडोरिज्म डोमेन, ठीक है, और बड़ा चैलेंजिंग केस था, बड़ा अच्छा ऑपरेशन किया माशाल्लाह, एक्सीलेंट, क्योंकि ये जो डाइवर्जन स्टूडेंट होता है ना, ये बड़ी मुश्किल से वापस आता है. You have to do extra lot of dissection and dissection. Normal जो 6-8 वाली जो portion है ना, वो इसमें नहीं रख सकते. हमें ज्यादा खींचना पड़ता है. आप नीचे क्यों गई होती है? क्योंकि superior oblique काम कर रहा है. तो once category sternotomy उसको काट कर दें या उसको transport कर दें. Instead of superior rectus के वो temporarily insert होता है, उसको आगे nasally कर दें, this is called superior oblique transposition. इससे वो बजाय डिप्रेसर के एलिवेटर बन जाता है. आंख नीचे नहीं होती, वो ऊपर आ जाती है. और अगर आंख एक्स्ट्रा रिसेक्शन से ना सीधी हो तो फिर हम लेटरल रेक्टस को काट के उसको ऑर्बिटल वॉल से लगा दें या मीडियल रेक्टस को ऑर्बिटल वॉल से लगा दें. The aim is to align the eyes in the primary position of gaze. जब बंदा सामने देख रहा है उसकी आंखें सीधी होनी चाहिए. Forget about the ocular movements. वो बात की बात. So our task is to align the eyes in primary position of gaze.
बेसिकली ये कोई बात साइंस से तल्लक नहीं रखती, ये बेसिकली प्रेजेंटेशन से तल्लक है. If you are presenting a scientific knowledge or anything in PowerPoint presentation, the basic thing you should know that a PowerPoint slide shouldn't have more than 6 lines. ये सबको पता होना चाहिए. इसके लिए रेजिडेंट से लेकर सबको, जब भी आप जिंदगी में स्लाइड बनाएंगे 6 से ज्यादा लाइंस नहीं होनी, 6 से भी कम होनी चाहिए. 6 इज द मैक्सिमम लिमिट. तो ये बेसिक असूल है किसी भी साइंटिफिक प्रेजेंटेशन का. ये कौन पढ़ सकता है और इसका पढ़ना अच्छा नहीं लगता. ये इनकी मैं प्रेजेंटेशन के लिए नहीं कह रहा, ओवरऑल दिस इज जनरली एक्सेप्टेड टूल. दूसरा, ये रेड और येलो कलर, देयर शुडंट बी रेड एंड येलो कलर ऑन योर स्लाइड. ये दो चीजें रेजिडेंट्स के लिए कि बेसिक ये अगर ये अपनी फ्यूचर प्रेजेंटेशन में जैसे लाहौर सलमा में होगी या कहीं और करते हो तो इनको अपने माइंड में रखने क्योंकि ये इसके भी नंबर है. ठीक है, थैंक यू.
Thank you very much. Regarding the previous case, glaucoma wala case mein Dr. Azam who's online, who's an international speaker, is basically, I would like to share his comment. Let your team know that the micropulse has become very prominent in the US for the refractive glaucoma. So this is a point that I would like to add, presented by Dr. Azam. So now going ahead towards the last presentation, the local presentation of our department, Dr. Komal, I would like to invite Dr. Komal.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Komal, resident ophthalmology at Jinnah Hospital, Lahore. Today I'm here to talk about optic disc pit maculopathy. So patient 37-year-old male, married, resident of Shahzara, Lahore, presented to us with a complaint of decrease of vision in the right eye from the past 1.5 years. Upon taking further history, we came to know that the decrease of vision was gradual on onset, painless, progressive, and it was associated with distortion and narrowing of images. Micropsia was present on the central field. There was no history of floaters, flashes, any redness or discharge, and no such complaint was present in the other eye. On past ocular history, the patient gave history of subtenon kenacort in the right eye from elsewhere almost 1 year back. There was no significant medical history of any systemic illness or trauma in the past. Now coming to the ocular examination. The visual acuity of the patient in the right eye was counting fingers, while in the left eye was 6/12. The visual acuity improved in the left eye to 6/6, while there was no improvement in the right eye. With pinhole, the visual acuity of the right eye worsened. The examination of adnexa, corneal pupils showed no obvious effect. On posterior segment examination, the disc was round, regular, with a temporal cavitary lesion almost 2/10 of the disc size seen. The cup was deep. Neuroretinal rim was seen to be decreasing circumferentially more on the temporal side. There was altered foveal reflex with a small central red lesion on the macula with irregular borders. On the endoscopy of the left eye, the disc was round, regular, CD ratio was 0.5, the macula, the neuroretinal rim was healthy, and the foveal reflex was good. Here's a fundus photograph of the patient's right eye. As you can appreciate, a cavitary lesion on the temporal side of the pit can be seen. We got the optical coherence tomography scan of the patient done of his right eye. Here you can see the serious macular detachment with extensive edema in the inner layers of the retina. Now coming to the differential diagnosis. The differential diagnosis include optic disc pit maculopathy, central serous chorioretinopathy, morning glory anomaly, and optic nerve coloboma. Now from the OCT scan and the history of the patient, we came to the diagnosis of optic disc pit with associated serous macular detachment. Now what we did in this patient? In this patient, we performed 23-gauge pars plana vitrectomy with internal limiting membrane peel with autologous serum and endotamponade of SF6 gas with face-down posturing for 1 week. Here's the video of the procedure. After doing pars plana vitrectomy and inducing PVD, we are doing internal limiting membrane peel using the island peeling forceps. Island flap is being inserted on the pit. Here you can see autologous serum that has been drawn from patient's arm is being placed on the pit. Here the island peel is being completed. Now, as you can see here, air fluid exchange is being done. Any accessory fluid is being aspirated, and the serum is allowed to stay on the pit for about 30 seconds. The sheen you see is because of the air. Finally, the procedure is completed with an endotamponade of SF6 gas. Now coming to the post-op follow-up. We got the patient's OCT scan done 2 months post-op and then 12 months post-op. As you can clearly appreciate, the edema had considerably resolved. 2 months post-op, there was some edema still present, which completely resolved at almost 12 months after the surgery. And the patient's visual acuity improved to 6/12 in the right eye. Now coming to the optic disc pit. What is optic disc pit? Optic disc pit is a congenital abnormality with a prevalence of almost 2 in 10,000. It is a small collabomatous abnormality caused by incomplete closure of the optic fissure, fetal fissure in the optic disc region. It presents as a solid, ovoid, gray excavation of the disc, commonly in the inferotemporal quadrant of the nerve. Visual acuity is typically not affected unless it is associated with cystoid macular edema, schisis, or serous RT. In patients with optic disc pit, maculopathy develops in approximately 25% to 75% of the patients. It most commonly occurs in the third and fourth decade of life, and it is caused by intraretinal and subretinal fluid at the macula, causing visual deterioration. Vision may be reduced to 20/200 or even worse. Now, talking about the pathogenesis of the optic disc pit, there has been a lot of research going on the source of the fluid or the origin of the fluid causing the optic disc pit maculopathy. The first possible source is thought to be the vitreous. The second possible is the cerebrospinal fluid, which is proposed to enter the intraretinal and the subretinal spaces through the optic disc pit defect. Third is the leakage from the blood vessels, and the fourth possible source, which is very much unlikely according to the literature, is the choroid through the Brooks membrane. Now here I have shared an article from the International Journal of the Retina and Vitreous. Here Elam et al. States proposed two theories of optic disc maculopathy development. He states that one of the reasons of the development of maculopathy is vitreous liquefaction that causes vitreous fraction, which basically occurs in the third and fourth decade of the life. Second, Linkoff et al. Stated that regardless of the fluid from the optic disc pit basically creates an inner retinal separation that leads to the formation of macular hole, which causes the dissection of the fluid subretinally and finally causes the formation of outer retinal detachment. Now coming to the management of the optic disc pit maculopathy. Again, there's been a lot of research going on as to what is the most appropriate management of optic disc pit maculopathy. We have gone through literature and have attached a few articles in the coming slides. The earlier initial approach involved conservative treatment and oral corticosteroid. Laser photocoagulation was also done, which involves applying laser at the intratemporal margin, causing chorioretinal adhesion and prevention of the invasion of fluid into the macula. Here in this article, the author states that laser photocoagulation did show some of the most favorable results, but it resulted in some visual field effects in some of the patients. Now, the mainstay and the current approach treatment of the management of the optic disc pit maculopathy is pars plana vitrectomy. This is usually in combination with laser treatment, gas tamponade, or internal limiting membrane P. The more recent use of internal limiting membrane flap has been introduced, which involves covering the optic disc, excluding the fovea, and it has demonstrated favorable results. The final step, as we've shown in the video, involves gas tamponade with SF6 or C3F8, which forms a temporal barrier blocking the passage of the fluid. Here in this article in the Asian Pacific Journal of Ophthalmology, Salvador et al. Stated that out of 41 patients, only one patient did not show favorable results with pars plana vitrectomy. Hence, pars plana vitrectomy still shows most favorable results for the management of optic disc pit maculopathy. There are other treatments also, which include pneumatic tamponade and macular buckling. So what happens in macular buckling is that it involves the fixation of an implant at the posterior pole from 6 to 12 o'clock meridians, which creates a barrier and blocks the passage of the fluid from the optic disc pit to the macula. In this article, Salvador et al. Again stated that even though macular buckling has shown favorable results with very less side effects, its role is seen to be controversial because the approach is difficult and it has a long learning curve. Now, quickly concluding it, here's an again article I shared. So now quickly concluding it, macular buckling proves to be very challenging for the surgeons despite its favorable results. According to the literature, the mainstay treatment of the optic disc maculopathy is sparse plantar vitrectomy, and it is worthwhile to induce PVT by performing sparse plantar vitrectomy to relieve any traction. Additional elements such as peeling, subretinal drainage, glial tissue removal still remain controversial. These are the references of the articles and the information I've used in my presentation. At the end, I would like to thank my faculty members, Dr. Qasim Lateef, our Associate Professor, Dr. Raza, Dr. Usma, Dr. Mohammad Hassan, and Dr. Vikas for helping us with this presentation. Thank you so much.
अच्छा पहले तो मेरा आर्टिकल चेक यू रेफरेंस मजे अच्छा इसमें दो तीन चीजें क्योंकि ये मेरा दैट्स माय फेवरेट टॉपिक इन retinopathy split because it's a rare disease and you hardly get 1 or 2 cases in a year. So interesting thing is the best technique till the day we couldn't find. The reason why it happens serious detachment is unclear. The most important factors that may impact serious detachment comes is vitreous or either it's from CSF. And in few cases it's from both sides because we have experienced that once it is coming from vitreous, you just do the vitrectomy and serious detachment goes away, even the pit is open. And there are the cases where you even close the pit and it doesn't happen. Why? The mechanism may be one, two, or both. So even knowing all these two mechanisms, we are still unclear. For example, in one case, I am closing the pit completely. And I have peeled the ileum on the nasal retina. It should close according to the pathogenesis because vitreous has been removed, pit has been closed, but serious detachment stays. So it means that there is some other mechanism also that plays roles in the serious macular detachment. By the day, no technique is ultimate or no technique is definite. There are multiple techniques. Qasim knows every year there come new techniques and they are followed by more new techniques. The best technique nowadays is more popular is the nasal. You can take the nasal ILM and you just dip it into the optic disc pit and just fluid air exchange rather than peeling over the macular area. If you go for the peeling on the macular area, it will end up in the secondary macular road. So no logic to peel the ILM over the macular area or involving the foveal area. Just peel it on the nasal temporal area of the optic and just dip it in the optic disc pit. Second that I mentioned in our editorial, we have done a punctum plug that has been put in the optic pit and that has been coming in the 7th edition of Rayan Retina and hopefully that will be a separate technique and that will be published. So there are a lot of things, pathogenesis is still unclear, but you have to consider 3 at least mechanisms. Because Qasim knows we had a case where just we did the ILM, just did the vitrectomy and everything went fine and we got good vision. But there are cases where you do everything and you don't get good results. So it's the issue of pathogenesis. Any addition or points? So very good case presentation and very good results. It's very rare that you get. You wouldn't get results in first 6 months, whatever the success rate you have. In optic speed, you get results after 9 months to 1.5 years, and then you have to follow. It may recur after 2 or 3 years. So this is very tricky disease, but very interesting disease. Thank you.
Thank you very much, Dr. Kamal. First of all, I'd like to all of you that we give a round of applause to all the residents in लोगों की जो तालियां जिन्होंने और इसमें जरूरी ये था कि मतलब just keep in mind कि ये presentation जो है ना 4 साल के बाद तकरीबन 3 साल के बाद हम दे रहे हैं 3 साल बाद ये हॉल जो है इस वक्त फुल है और अदरवाइज 3 साल पहले हम मीटिंग्स कर रहे थे और उसके बाद कोविड जो है 3 साल जो है इसमें गैप आया नदीम साहब हमारे साथ इस वक्त मौजूद नहीं है और अल्लाह ताला ने उनको जो है हमसे इससे ज्यादा जरूरी काम के अपने पास बुलाया है हज के लिए और इंशाल्लाह he will be back by 20th and now I would formally like to invite and start the presentation of our international speaker for today, Dr. Azam Qureshi. He's basically Chief of Pediatric Ophthalmology in Strabismus, CPMC, and Assistant Professor of Pediatric Ophthalmology, UCSF, United States of America. So we'll start with his presentation, and then we'll be online. He'll be online to take the questions. He is online at the moment, and he'll be online to take any questions from any one of us.
Assalamu alaikum. My name is Azam Qureshi. I'm an assistant professor of ophthalmology at UCSF. I'm the chief of pediatric ophthalmology and adult business at CPMC, and I'm also the medical director of ophthalmology at the Children's Hospital of Oakland. I would like to thank the Ophthalmological Society of Pakistan, Lahore branch, for inviting me to speak. I'd like to extend a special thanks to Professor Naveem Hafiz Butt, who's the head of ophthalmology department at Jinnah Hospital in Lahore, for inviting me. Thank you so much. And I'd also like to thank Professor Qasim Latif Chaudhry, the professor of ophthalmology at Jinnah Hospital, Lahore, as well. Thank you so much. Lastly, I'd like to thank Hassan, who is my co-fellow at UCLA, for reaching out to me to do this talk. I'm always happy to share what I've learned in my experience as a strabismus surgeon. All right, so we're going to be talking about the role of botulinum toxin in pediatric strabismus. So to start, we have a case, and I feel like the best way to choose why Botox is so important in pediatric strabismus is to go by a case and see how the family feels about surgery and talk about the dynamics of that interaction. And you can really see how Botox comes out as a great option for families. So we have a 5-year-old female presenting with intermittent diplopia. She wears glasses every other day when she has and she has double vision with and without the glasses that every other day. Her ocular history is significant for hyperopia, astigmatism, pseudoesotropia, no prior surgery, family history, other history of myopia. She lives with her parents, has no siblings, she has no significant past medical history. Of note, she had been seen by 2 other ophthalmologists, both at Stanford and a private practitioner. So her visual acuity was 20/40 on the right and 2400 on the left when I saw her, and when I saw her on a quote-unquote bad day. She had equally round pupils, reacted to light, no APD. Her pressure was soft in both eyes. Her extraocular motility was full. She had color vision that was normal in both eyes. Here's a picture of her when she presented to me, and you can see significant esotropia. When we measure her, she was measuring 45 prism diopters of esotropia at near and 10 prism diopters of esotropia at distance. So, we have a 5-year-old female here with intermittent diplopia. The differential diagnosis is as below. Dry eye can cause intermittent diplopia, strabismus can, superior oblique myokemia, convergent spasm, divergence insufficiency, and acute esotropia. Upon further history, as we said, mother said she had good days and bad days, and each day lasts for 24 hours, including the day of presentation. So upon further review, we made the diagnosis of cyclic esotropia. All right, so a little bit of background of the diagnosis. All right, so a little bit of background of the diagnosis. This is also known as alternate day esotropia or circadian esotropia. It's a rare form of strabismus. It alternates periods of esotropia and orthotropia in a 48-hour cycle. So that means a 24-hour period of orthotropia followed by a 24 period of esotropia. Usually occurs in preschool years. It's non-accommodated esotropia type, and no one understands the pathophysiologic mechanism of it currently. There's theories, but I'm not sure. How do you make the diagnosis? Basically by history and clinical findings. The strabismus day, there's a large angle deviation with poor fusion and binocular vision. On the straight day, the patient's typically orthotropic and improved has improved fusion of vision. The natural evolution of the diagnosis is that eventually you break the cyclical pattern and these patients go to having constant esotropia. So typically, the disease is managed surgically. Some people recommend doing half the bad day deviation. Some people recommend doing full. Most people common consensus do the full amount, and you do a bilateral medial rectus recession. Given the young age of these patients, they're typically preschool age, as we mentioned earlier, which is under the age of 4. You know, Botox is, arise as an alternative. So, you know, a little bit about Botox. It's an injectable neurotoxin. It inhibits muscle contraction by blocking the release of acetylcholine at the neuromuscular junction. Botox was originally designed to actually treat strabismus before the cosmetic uses for eyelids, amongst other things like facial spasm. It was invented by Alan Scott, who actually lived in San Francisco. Me and Hassan trained at UCLA together, and we were fellows there. And it actually was, we didn't commonly use it to treat strabismus at UCLA, but I had the great fortune of moving to San Francisco and practicing over here. And Alan Scott was alive and practicing when I started. He would give me great guidance on when it was applicable to Botox and when it wasn't. So I had quite a bit of experience using it before, unfortunately, he passed away a few months ago. But he still was always accessible to me up until recently. So in this case, you know, in this case, you know, this is, as we mentioned, you know, the reason why I wanted to show this in the context of a case is this is a surgery sparing strategy, right? And so parents are always looking for ways to prevent surgery. And there were case reports out, there were 9. I talked to another physician who had done it before proceedings. And the idea is, you know, you break the cycle. You do bilateral medial rectus injections about 5 units. The small angle esotropia and orthotropia can remain, but usually binocular stereopsis is regained. Here is the case series. Here is the case series of the 9 patients, and as you can see, these patients are all between the ages of 2 and 5, aside from that one 57-year-old. And all of these patients, you know, typically we're getting either one medial rectus of 5 or split between 5. We opted for splitting, for doing 5 in each. You know, so kind of a review of what are the upsides and downsides of using Botox. It's safe in children. There are some adverse effects such as transient ptosis and vertical deviation that can happen from the Botox slipping from the medial rectus surrounding tissue. But the upside is there's no scar and short anesthesia time, and that's very, like parents like that. So I actually recommended bilateral medial rectus recession. This is one of my first times. Like I mentioned, I wasn't using Botox regularly in my fellowship, but the parents asked me for the non-surgical option. So obviously I reached out to Alan Scott, the inventor, as I mentioned earlier. He said this is a great option for it. He had never done it himself with cyclic esotropia, but this was exactly kind of what he had intended. He wanted basically something like this, you know, where Botox lasts for 90 days, and it would definitely break the cycle and allow the patient to restore full-time binocular vision, even well after a week. So I proceeded with performing bilateral medial rectus muscle Botox injections. I gave 5 units to each muscle under general anesthesia. It probably took around 5 minutes, and there were no complications. There were no severe complications, but as you can see here on post-operative day number 3, I was wishing I had just done medial rectus recessions because there was a little bit of ptosis, significant, and there was also exotropia. On post-op day number 10, though, most everything had kind of resolved and things had significantly improved. And by post-op week number 6, there was no diplopia, mom said the straight, eyes were straight every day. And I'm still in touch with the mom. We're a year out, and mother has had no recurrence since. So it was effective and it worked 1 year out. even well after the
So a little bit about the
Botox.
history of Botox.
So a little bit about the history of Botox. Botulism toxin is formed by Clostridium botulinum. It's toxic to human. It causes flaccid paralysis, can be seen in this picture.
Drockman's work and Johns Hopkins showed it.
Drockman's work and Johns Hopkins showed it was effective in paralyzing muscles. My mentor, Alan Scott, and his colleagues were amazed by Drockman's work, and they said, hey, this would be a great way to try and treat strabismus. So they found when they injected the extraocular muscles of monkeys that a few picograms could cause tremendous long-lasting effects. The first patients, human patients, extraocular muscles were injected in 1977. In 1984, he received FDA approval and Botox became accredited. He eventually sold it for the rights for about $16 million and is currently a $1 billion a year grossing medication.
So I wanted to take you guys through the steps.
So I wanted to take you guys through the steps of using it because Hassan had informed me that it wasn't commonly used in Pakistan. Basically you have the Botox that needs to be reconstituted. So you have a 1 milliliter syringe. You take a 0.9 sodium chloride and you take 1 milliliter of that. You inject it in here and into the 100 units. And then basically what you have is you have 0.01 correlates to 1 unit of Botox. And and then if you want to do 4 units, it would be 0.04. You want to do 5 units, plus 0.05, and such. And this is kind of recommendation split between the two eyes. If you want to treat between 11 and 20, you would do 2.5 units. You want to do between 20 and 30, you do about 5 units each. And you want to do between 30 and 40, you do more.
So I wanted to take you through an example.
And so I wanted to take you through an example of a patient that I performed it on. And so I had a patient that I was performing it on this week, and I had my staff record it so I could show you guys how we do it. So we basically we use an Mendonça forceps. And so first I abduct the eye, and I use the Mendonça forceps to grab the medial rectus. And you can see it bunches up nicely when the Mendonça forceps grab it. It's very important to have an assistant place Q-tips on either side of the medial rectus muscle to prevent leakage of the Botox to inferior rectus or superior rectus or the levator. And you can see here I'm injecting, and it's 1 for every 0.1, and so I'm injecting 5 over here. This is a non-accommodative esotropia patient we're going to get into later. And you can see I successfully do it. You can see the meniscus comes down for 5 units. And I have my staff member hold the Q-tips there well after for a minute to prevent the leakage. I performed the same thing on the other eye, but I didn't record it.
So, where are some other instances where you
you can use Botox? Here's a case of congenital esotropia where we used Botox, and 1 year out, this patient was doing great after we injected both medial rectus muscles, and we prevented the need for surgery.
However, it doesn't always
work in these cases. This is a congenital esotropia patient who, this first picture is after Botox, and it did not work. And so I had to perform a bilateral medial rectus resection, which did eventually work for this patient. But mother was happy to perform the second procedure and was happy to try to prevent surgery. As I mentioned earlier, Alan Scott's intention in creating this was to give a chance for the eyes to eventually swing into ortho position and let fusion build off of that new positioning. And so he actually designed it exactly for
Another instance where I use it
is in accommodative esotropia with a non-accommodative component or high AC to A ratio.
There's a 9-year-old male I performed
There's a 9-year-old male I performed who measured 25 at near with bifocals and only 2 at distance. So, and the visual acuity was 20/20 in the right and 20/30 in the left with no superior acuity. Patient was hyperopic with anisotropia and had left amblyopia that I was unable to break with patching the glasses. So because he measured 2 at distance, this patient wasn't really a candidate for surgery. So I ended up giving 3 units of Botox to both medial rectus muscles, and patient ended up becoming 20/20 in both eyes, and also had gross stereopsis. Patient also had no deviation in near or distance. So we see that Botox also was effective in treating astigmatism and amblyopia in this case, and in 2 or 3 other cases I've done just like this.
Finally, we have a cranial nerve 6 palsy.
Finally, we have a cranial nerve 6 palsies, and this patient is a patient who presented to me, had a pontine tumor bilaterally, and you can see esotropia measuring greater than 50. This first picture is actually after medial rectal recessions, which were ineffective. And then I did a modified Hummelstein procedure where I took the lateral portion of the superior rectus and inferior rectus muscles. I resected back 4 millimeters on these lateral portions and I put them by the lateral rectus. The effect was great. And you're like, well, that doesn't have anything to do with Botox. Well, actually, the patient eventually regressed. And you can see here
The regression a year later.
The regression
a
year later. And I only did 1 round of Botox. I did 7 units. I did 8 units each medial rectus muscles, and we had a great outcome with a little bit of ptosis on the right upper eyelid.
So the question is,
the question is, like what's the literature pertaining to this? The literature is actually pretty supportive of using Botox in childhood strabismus. You can see here that the outcomes are very good, especially for acute onset esotropia. Infantile esotropia really depends on the age you get the child. The later it is, the older they are past the age of 1, the harder it is because they never developed any stereo acuity. But you can see some pretty good results here in England from this one paper. Here's another paper by a group, and they showed very good results with partially accommodated esotropia, less so with infantile esotropia, but as I mentioned, that's all about the age. Obviously in Duane's it's misinnervation, so it's not going to work. And finally, in sensory esotropia, it's also not going to work because there likely is not good enough vision in the other eye to get anything to stick with the Botox. So that's my presentation. I'd like to thank everyone for giving me the time and hearing me out. I'd like to open up the floor to questions now. Thank you.
Thank you very much, Dr. Azam, for such a nice presentation. Any questions from?
So you can ask him.
Yes.
Hello, Dr. Azam. Can you hear me?
Yes, I
Dr.
can.
Azam, can you hear me?
Yes.
Okay. Thank you very much for an illuminating talk. It was very interesting indeed. My question is, how often you have to repeat the injection in the muscle? I mean, in 1 year, how many injections were required? Did you get my point?
Yes, I got your question. Depending on the type of Isotropia, you have to inject more. Juvenile onset.
Azam, can you please repeat your answer right now?
Can you hear me?
Can you repeat?
Should I repeat the question?
Yeah. So in the different types of esotropia, you set esotropia, do it again. Genital esotropia to get it to stick, and if not, sometimes you have to do a surgery the third time if it doesn't stick afterwards.
Any other questions? Thank you, Dr. Azim. Thank you for the deliberate talk, and thank you for coming online. Now going forward ahead, now we would like to invite our local speaker for today. He's basically a part of our family of Islamic Medical College. Now he's shifted to King Edward Medical University as a professor of ophthalmology. So we invited him as a guest speaker for today. I would like to invite Professor Dr. Hamad Ayub to give a talk on pediatric ophthalmology, biometry in pediatric ophthalmology. Yeah. Yeah. Yeah.
थैंक यू वेरी मच काशिफ बहुत बहुत शुक्रिया आपका इनवाइट करने का थैंक यू वेरी मच नदीम साहब का बहुत बहुत शुक्रिया वेरी ऑनर्ड mentor, very much. So, thank you very much, sir. A very controversial topic. बहुत सारी स्टडीज के ऊपर बहुत इजीली और जो किसी एक कंसेंसस पे नहीं पहुंच so still a very controversial topic but gradually we are coming to consensus that we have advanced and whatever may be the age of the child we have so जब हमें इम्प्लांट करना ही है तो
Bluetooth mode.
उसके कुछ challenges हैं
has been connected.
we come to that
FM record. Line mode.
So he is the person यहाँ पे भी इनकी फोटोग्राफ लगी हुई है जिन्होंने सबसे पहले IOL आंख में इम्प्लांट किया Mr. Harold Ridley. So his innovation or his invention that led to many marvels. जो हम आजकल premium IOLs, multifocal IOLs, all started from this guy, right? Magar the person in which the IOL was implanted, he had a refracted error of +2. So that is what biometry is. That is why biometry is there. So biometry is a method of applying mathematics to biology, and this term was originally used initially in the 1800s for calculating life expectancy. So the refractive power of the eye primarily depends, we all know that, कॉर्निया के ऊपर, कॉर्निया के refractive power के ऊपर, lens के ऊपर, ocular media and the axial length of the eye depend upon these structures. So when planning for cataract surgery, in order to achieve the desired post-operative protection, the required power of the intraocular lens can be calculated. ये हमें सबको पता है कि कॉर्नियल रिफ्रैक्टिव पावर का पता होना चाहिए, मीडिया टाइप का पता होना चाहिए, एक्सियल लेंथ का पता होना चाहिए. So intraocular lens implant in pediatric population is gaining popularity. पहले था कि जी बच्चों में इंट्राओकुलर लेंस जो है वो नहीं इम्प्लांट करना, बड़ा हो जाए तो फिर करना. Surgical management of pediatric cataract has greatly improved over the years. बड़ी अच्छी हम सर्जरी कर लेते हैं, बच्चों में भी रेक्सिस बड़ी अच्छी हो जाती है, पोस्टीरियर रेक्सिस भी बहुत अच्छी कर लेते हैं, ठीक है. और इन्फ्लेमेशन जो शुरू में होती थी कि जिसको मैनेज करना मुश्किल होता था, उसको भी बड़ी इजीली आजकल मैनेज किया जा रहा है. So that's why today more surgeons are opting for IOL. In pediatric age group, surgeons are even opting for IOL implant in infants less than 6 months old. उसमें भी डाल रहे हैं. Advantages क्या हैं IOL implant की? Optimum radial rehabilitation, improved visual acuity होती है, binocular single vision you attain that. There is reduced chances of strabismus, maximum visual outcome in unilateral cataracts. Disadvantages, visual axis opacification हो सकती है, and the main thing is that is the myopic. So what are the challenges in calculating the intraocular lens implant in the power of the intraocular lens implant in the pediatric population? सबसे बड़ा जो challenge है वो myopia. The eye is growing. दूसरा जो challenge है कि ये जो shift होती है, how much it is, और किस age में कितनी होती. Once you know that, what should be the target refraction post-op, और उस टारगेट रिफ्रैक्शन को अचीव करने के लिए आपने एक्सियल लेंथ मालूम करनी है उस एज ग्रुप में, और उसकी केराटोमेट्रिक फाइंडिंग मालूम करनी है उस एज ग्रुप में. और इन द एंड यू नीड टू हैव अ फॉर्मूला टू अप्लाई दिस, राइट. और उस एज ग्रुप में कौन सा वाला फॉर्मूला जो है, देयर आर सो मेनी फॉर्मूलाज, राइट, व्हिच इज मोर. So implanting a fixed power IOL in a continuously growing eyeball, that requires complex decision making process. ठीक है, बड़ों में तो हम बड़े आराम से IOL की पावर कैलकुलेट, reasonably good results, ठीक है, और बिल्कुल एक्यूरेट रिजल्ट मिलते हैं. आजकल तो ये जो IOL मास्टर वगैरह इस तरह की चीजें हैं, it's quite easy, ठीक है, and we get very good. But in children, the things are different. And we frequently come across surprise. Right? और ये surprises जो होते हैं ये post-operative refractive results की वजह से. Some of them they are early surprises, and these surprises, and some of them they are late surprises. Early surprises हैं वो inaccurate IOL calculation की वजह से, and the late surprises they are due to this myopia. So pediatric IOL power calculation is still controversial. Why? While the surgical management of cataract pediatric cataract has improved, the accuracy of iron power calculation has not shown similar improvement. Why? All the calculation formulas, they are designed for adult population. They are less accurate for small excellence. Biometry has to be done under anesthesia, which is not ideal. And the skilled technician who normally does your biometry is not available. You have to do it yourself. Right? Now, there is a concept of emetropization. Emetropization. The human eye undergoes extensive changes during early childhood, include axial elongation, corneal flattening, and the reduction in the lens power. This is known as getting towards emetropia, right? So, how does this normal growth or emetropization? Okay, it happens. Axial lens जो है वो usually बच्चा पैदा जब होता है usually an infant is around 17 and it goes up to 23, 24. Right? Corneal power it is around 51. Okay? It reduces to 43.6. And the lens power it is around 34 and it goes to 18.6. So this is the main thing, right? This power shift of the lens from 34 to 18.6. That is you need to keep this in your mind because you are removing this lens. And that lens it's now you're implanting a fixed power lens which hasn't got the capacity to change its power. And the original lens, the real lens or the crystalline lens, had to move from this much diopter to this diopter to achieve emetropia, right? So this thing we have lost. And how much we lose at what age group, at what age group, that is to find out. So maximal eye growth occurs in the first few years. The change in mean keratometric values occurs primarily in the first 6 months. More than 50% of the axial growth occurs during the first year of life and maximum during the first 2 years. That is why there is near consensus that 2 साल पे तो डालना ही डालना, ठीक है? There is still controversy कि 2 साल से पहले डालना है कि नहीं डालना. Length and the total eye power decreases about 10 diopters during the first 2 years and only about 3 to 4 diopters up to 10 years when it's stable. So pediatric cataract surgery results in loss of the nasal crystalline lens prior to the completion of the complex process known as the emetropization. And after crystalline lens is removed surgically, every millimeter of axial growth of globe changes the refractive error of the eye by more than 2.5. Okay. In contrast, about 0.9 diopter refractive change occurs in normal phakic eyes, and aphakic eyes have an average myopic shift of 10 diopters from infancy to adulthood. So this इतना फर्क पड़ जाता है. So the myopic shift during the first 1.5 years is about 4.19 diopter per year. That comes to about 0.35 diopters per month. Right? And it is 0.97 diopters after 1.5 years or 0.08 diopters per month after 5 years. the rate of myopic shift is independent of age at cataract surgery, keratometric reading, and IOL power or the agreement. So here we have gotten a study here, and if you see that the maximum growth it occurs during the first 2 years of life. The शुरू में ये जो curve है, it's very steep, and then it's usually it stabilizes as the child grows older. These are the different studies showing at what age group how much there is a shift in power, right? So Wilson की study है, Krauss की study है, Plager की study है. These are the studies which are usually taken as reference for calculating the iron power, right? So these are the different studies, and you can see that during the first few years there is a maximum change in the refractive power, and the later years there is very minimum change. There is not much difference in growth pattern of pseudophakic or aphakic eye from the phakic eye. That you should keep in mind. Measurement of axial lengths in pseudophakic eyes, aphakic eyes, and the unoperated fellow eye in cases of unilateral cataract have shown no significant difference in change in axial length over time between the two eyes. That you should also. Most of the children below 2 years at the time of cataract surgery, with or without IOL implantation, have greater variance in the refractive change than those older than 2 years at the time of surgery. So, what should be the post-op target refraction, and at what age? The target post-op refraction, it depends upon the normal growth, which we have discussed earlier. Literality, whether we are dealing with a uniocular cataract or we are dealing with a binocular cataract. If we are dealing with a binocular cataract, दोनों तर bilateral cataract, so in that case, हमें थोड़ा सा leverage मिल जाता है, right? But in case it's a unilateral cataract, that is a big challenge. We have to be as close to the refractive status of the other eye to prevent the formation of amblyopia, right? Then it also depends upon the genetics. You have to keep in mind the genetics of the patient. अब अगर उसके वालिदैन उधर है, उन्होंने भी मोटी आंखें लगाई हुई, ऐनकें लगाई हुई हैं, तो you have to keep that in mind कि ये patient myopic हो सकता है आगे जाके और या hypermyopic हो सकता है, right? Visual input. एक पेशेंट है, उसको बहुत देर से कैटरेक्ट, it's an old standing cataract, so that eye must be embolic, ठीक है? तो आप ऐसे पेशेंट को बहुत ज़्यादा hypermetropia usually do, we will not do that because already patient is amblyopic and you cannot induce more amblyopia by implanting an IOL having so much less power, inducing hypermetropia. उसको आप aggravate and obviously age at surgery. So the ultimate goal of the pediatric IOL power selection is to provide a manageable course of refraction between IOL implantation and adulthood with the best possible adult visual pattern. Okay? But mind it, these children usually, unless they आप कोई बहुत बड़ा mess up ना करते, usually these children they remain with you. Okay? Once they come to you, उसके बाद वो आपके साथ ही रहते हैं जब तक बड़े नहीं होते, ठीक है? So that you have to keep in mind. So there are three basic approaches. एक तो है कि aim for emetropia, जो उसकी रिफ्रैक्टिव पावर आती है जो आपने कैलकुलेट की है और अगर आपने ठीक कैलकुलेट की तो वही डाल। दूसरी ये है कि जो बच्चा अब जाके 15-16 साल 18 साल की एज में जो उसको डलना है वो वाला आईवल डाल दें। और तीसरी ये है कि जस्ट मेक दैट पेशेंट माइल्ड टू मॉडरेट। तो इन सब की कुछ एडवांटेजेस हैं कुछ डिसएडवांटेज, ठीक है। ईमेट्रोपिया ये है कि अगर आपने उसको ईमेट्रोप किया है तो यू मस्ट बी रेडी। मिनिमल रिस्क ऑफ एम्ब्लियोपिया, child ends up with large myopia in adulthood. Many surgeons like this approach due to recent advances in management of myopia, right? तो आप सबको पता आपके सामने एक पेशेंट आ जाए वो हाइपरोप हो या मायोप हो, किससे ज्यादा खुश हो? तो मायोप को ज्यादा मैनेज करना जरा आसान होता है, राइट? So how do you manage myopia in these cases later on? आप IOL चेंज कर सकते हैं, piggyback IOLs यूज कर सकते हैं, and obviously you have effective surgery options. If you implant an adult IOL power, so goal is to achieve emetropia as the child reaches adult, right? मगर ये तो आपने गोल रीच कर लिया, right? But results in large amount of hyperopia which must be corrected. Near vision is most affected and it is highly amblyoptic. उसने ऐनक लगानी है नहीं लगानी है, पेशेंट काउंसलिंग बड़ी जरूरी है, पेशेंट की पेरेंट काउंसलिंग बहुत जरूरी है, वो असली काम तो पेरेंट्स ने करना। Midway between the two approaches is mild to moderate hyperopia that is most widely practiced, and goal is to achieve the amount of hyperopia which can be easily handled to avoid amblyopia. Right? एक उसमें रूल ऑफ 7 है, एलईडी साहब ने ये इन्वेंट किया था, that 8 plus hyperopia should come to 7. तो अगर 2 साल का बच्चा है तो आप उसमें 5 ऐड करेंगे तो it should come to 7. But I think at 2 years of age, 5 diagnosis the hyperopia is still too much, right? It will still create right? But there are certain other studies, जिसमें राउथ की स्टडी है, ऑनर की स्टडी है, जिसमें उन्होंने डिफरेंट एज ग्रुप्स में बताया कितना आपने उसको हाइपरमेट्रो, so almost similar studies and widely used, right? फिर हचिसन जो है वो कहता है कि जी आपने इसको ईमेट्रो करना है, और जस्ट +1 का आप टारगेट करना, ठीक है? वो हर एज ग्रुप में उसने 1 रखा, ठीक है? तो ही इज एडवोकेट ऑफ ईमेट्रो, कीपिंग द पेशेंट ईमेट्रो। जो डॉर्थी है वो कहता है कि ये भी ईमेट्रो एडवोकेसी करता है, वो कहता है कि जो पावर आई है उसका 25% लेस कर दें, राइट, इन द फर्स्ट 6 months। और ये बात कर रहा है किसकी? इन्फेंट्स की बात कर रहा है, राइट? कहता है फर्स्ट 6 months 25% रिड्यूस कर दें और अगले 6 months 20%। इसी तरह गामान, इसकी जो स्टडी है वो कहता है कि जी जो लेंस की पावर आई है उसका 80% एट 1 year कर दें और उसके बाद 90%, जो पावर आई है उसका 90% जो है वो आफ्टर। older children में क्या करना है? 2 to 4 years IOL power is equal to the spherical equivalent of the fellow eye. ठीक है? अगर आप you are dealing with the uniocular gap. और अगर more than 4 years है तो जो उसकी spherical equivalent दूसरी आंख का आता है कोई ठीक है. So infants में adult IOL power डालेंगे. Obviously we have already discussed कि क्या हो सकता है उसमें. So amblyopia very high. ठीक है. Emmetropia करेंगे तो you must be ready for these things. Infants में ये विल्सन की स्टडी है ठीक है और विल्सन कहता है कि लेस देन 6 months मॉडरेट हाइपरोपिया आपने अचीव करना है और अगर 12 months उसमें माइल्ड हाइपरोपिया 0 स्पीड है. 4 to 6 weeks people are implanting 4 to 6 weeks. So plus 8 after plus 9 or 6 weeks to 6 months after plus 6. So important to find out the refractive status of the fellow eye in case of monocular cataract or with pseudophakia to minimize anisotropic. Right? When surgery is done in both the eyes, large amount of hyperopia may be accepted. More easy to manage myopia than amblyopia. In case of dense amblyopia, leave less hyperopia to facilitate its management. Right? If compliance with glasses or contact lenses for the residual refractive error is poor, amblyopia may worsen. ठीक है? तो patient पेरेंट्स की काउंसलिंग तो इट्स वेरी इंपॉर्टेंट लेकिन कई दफा आपको पता होता है कि ये कंप्लायंस जो है ना ये बहुत खराब है ठीक है. इन दैट केस इट इज अप्रोप्रिएट टू लीव patient as much near to the emmetropia as it is possible. ठीक है. So it is better to leave the least possible refractive. So if the site of the IOL placement is changed, power adjustment should be made. So sometimes होता है कि you are not able to keep the bag, right? In the bag implant. So you are implanting it in the that case you have to adjust the IOL or 1 to 2 diopters when the IOL intended or in the bag placement is implanted in the surface, right? So aiming for emmetropia results in a large refractive error in the adult eye but simplifies treatment for amblyopia. Aiming for high hyperopia gives better adult refraction, avoids the need of repeat surgery, but complicates child amblyopia. Okay? And targeting moderate hyperopia gives more acceptable lifelong. ठीक है. तो इसमें और भी चीजें हैं एक्चुअली लेंथ की मेजरमेंट में क्या कॉम्प्लिकेशंस हो सकती हैं, व्हाट आर द पिटफॉल्स, कैरोटोमीट्री में क्या हो सकती हैं. We will leave it for some other day, right? So we will conclude it here and determining the optimal eye power for children is as much an art as right. Thank you very much.
Thank you very much, Professor Hamad sir. Now we're heading towards the end of the clinical meeting. Now I would like to invite Professor Khan, Professor Hussain Ahmed Khan, the General Secretary of Ophthalmological Society of Pakistan, to award the prizes for the speakers.
done the presentation by residents, as I have already mentioned that these presentation will matter you for the end of the day. At the end of the year, those who are winning the first position, they will be participating in the grand clinical meeting at Lahore. So it is just an initiative to bring more passion and more sparks among the residents to work for the science. So all the presentation were very well done. Everybody did his best or her best. So there is no winner, no loser, but there is always first, second, or third position is always there to just encourage. So just for encouragement, the judges have announced the result, and the result is that the first position goes to Dr. Komal Khagar. Dr. Komal Khagar. I will request Professor Hamid Mahmood Bhatt sir to come in front. Professor Moin sir, Raja sir, please to come over here and present the certificate, and Dr. Komal, please. And here is a souvenir for the Raja. Now we have our second position, and that second position is Dr. Sana Chaudhary. Dr. Sana Chaudhary. I will request Professor Abdul please come over here. Thank you. And for the third position, we had a very tight competition, so we are having two winners for the third position. So you all know who are those two, Dr. Muhammad and Dr. Inamur Rahman. And I will request Professor Hamad to come over here and present the certificate to Dr. Muhammad Ahmad and Dr. Inamur Rahman. Dr. Muhammad, please. So we have one souvenir, so you have to share. You have to share this Parker pen. So please. Thank you. So you can use it for 6 months, and then your friend now will do it. So you can give it. You can have it draw. Actually, this was a draw. I just. Thank you. Thank you. Now I will request Professor Hamid Mahmood Bhatt to present a booklet and certificate to Professor Hamad Ayub for guest speaker and guest presenter.
I object to the word guest. I can never be a guest in this department. This is my home.
This is honor for you, they are guesting.
Honor is ours.
No, guest is ज़्यादा honor है. चलो next.
Thank you.
So and now I will request Hudson Pharma representative for hosting this meeting, and we are highly thankful for hosting this meeting, and it's a great privilege that you are getting for it. Please, Hudson Pharma representative, please. So now I will request Faisal to present a bouquet to the head of the department or the most senior representative at this time of this department. I think Qasim is not here. Sir, Cool. Okay, so now I will request Professor Mohammed Naeem to give a vote of thanks and invite for a lunch. Yes.
Thank you very much. I think hopefully you've enjoyed the meeting. It has been very informative. All the presentations were very well prepared. And the international talk was actually quite interesting. I'll just ask Hassan to ask his friend, do they use EMG there to inject the botulinum? But here, it was good that he showed it with the forceps because we are able to do that much easily compared to an EMG. As you know, OSB, you can see the cameras over here. These are your presentations are being recorded and you can find them on the internet. We've got a YouTube channel which is there for OSB and all your presentations are available there. And we're developing a new website for OSB in which you can get a link to that YouTube channel which you can share. We've already completed the website and we're going to launch it, but Professor Nadeem was not here, so we'll delay it and we'll launch it at a later date. So I think Professor Rana Nisha needs to say a few words before we call you for lunch. And thank you very much, Hudson Pharma, for organizing this event. And I always would like to invite you or sort of make you self-prepared for the upcoming Afro-Asian Council of Ophthalmology meetings being held in December. Along with the Lahore Ophthalmo, we will all be participating, and it is you who are going to be the main audience of the meeting, and we'll have international speaker. We have planned for about 60 or 70 speakers coming in, so it will be a good show. And General Secretary Professor Hussain Ahmad Khan is working very hard to get all the speakers here, and I'll encourage all the residents to prepare your papers and submit the scientific program in time. Our deadline for the scientific submission is coming at the end of July, so if you think your papers are good and you're working on them, please do submit them so we can have a great program for juniors and seniors, all of them. Thank you very much. And the next meeting is going to be 13th August in Children's Hospital. And Dr. Asma is here, she's going to be hosting the meeting. Thank you very much.
Thank you very much for this gathering. And I must thank Professor Dr. Ahmed Khatsa for coming, and also Dr. Humaira and Dr. Afzal, Dr. Tariq, Dr. Shuaib, Dr. Moeen, Dr. Khakan, and all the students who are present, and all the participants who are here, Dr. Hassan specifically, and OSP members, and Dr. Hashim as well. And I request all of you to kindly join us for lunch. Thank you very much. Thank you.
अभी पहले अपना मोबाइल